Hello everyone, in this module we're diving into a critical aspect of our work, caring for newborns. This is an essential topic because, as you know, every birth is unique and being ready to support these tiny humans as they make their grand entrance into the world is a skill we need to have in our back pockets. So why do some babies need a little extra help when they're born? Well, it turns out that the journey through the birth canal is more like an extreme sport. It's a hypoxic event. Oxygen supply from the placenta is reduced during contractions. Luckily, mature babies usually have some energy reserves to cope with this, but sometimes they need a little nudge to adapt to life outside the womb. Most babies handle this transition like pros. 85% of them breathe spontaneously without any help. And for the rest, another 10% just need a bit of drying and some stimulation or airway opening manoeuvres and they're off to a good start. For about 5%, positive pressure ventilation is needed, but intubation is only required in less than 2% of cases. Chest compressions and adrenaline? Those are really rare, but we must be prepared for anything. So, while most babies do great on their own, we do need to be ready for those who don't. Now, let's talk about how we can support these babies when they do need help. Newborn life support is all about getting the basics right. It starts with environmental optimisation, making sure that the room is warm and prepared. Then it's about umbilical cord management, thermal care, assessing the baby's needs, and, if necessary, moving through airway opening, inflation breaths, ventilation, and then chest compressions in the rare cases. It sounds like a lot, but it all boils down to having a systematic approach that we can all master. Environmental optimisation is something we can definitely all master. The first step is just to ensure that the room is warm. Not just for comfort, it's crucial for the newborn's stability. So close the windows. Then prepare a firm flat surface for possible resuscitation and have warm towels ready. If you're expecting a high risk delivery, consider calling in extra resources ahead of time, because it's all about being prepared for anything right from the start. Speaking of high risk scenarios, these are some of the situations where preparation is key. If you're dealing with twin deliveries, preterm births, or a history of maternal complications like preeclampsia, you'll want to ensure that enhanced care teams are on standby or travelling. Even something like shoulder dystocia or premature rupture of membranes means that we need to be on high alert. Always better to have more hands ready than to be caught off guard. Here's an example of what your newborn life support station might look like. It's a good idea to get this set up before you need to use it. Essential items include towels, the transwarmer, airway and breathing equipment with a range of mask sizes and oxygen, monitoring equipment, and the all-important NLS algorithm, which you can download and print from the additional resources section of this module. You want to have your communication equipment close to hand and a timer. That's really important. And so is a stethoscope. All of this ensures that you're ready for all eventualities and can concentrate on following your systematic approach to caring for the new human that's on the way. Now, let's move on to cord management. We've come a long way from the old days of immediate clamping. These days, if the baby is breathing spontaneously and doesn't need an immediate intervention, we can delay cord clamping for at least 60 seconds, or even until the cord becomes white. This allows more blood to flow from the placenta to the baby, which can be incredibly beneficial. Let's take a moment to watch this video on cord management.
At birth, a third of the baby's blood volume is still in the placenta, and it's really important that the baby gets that extra blood. So we would recommend that for the first 60 seconds after birth, the cord stays intact for every baby. And during this time, the focus is to dry the baby if the baby's term, and focus on thermoregulation. You're also going to be assessing the baby, colour tone, breathing and heart rate, whilst the cord is intact. If the baby's well, the cord can stay intact until the cord turns white. If the baby requires resuscitation, at 60 seconds, clamp and cut the cord. We're now going to demonstrate how and where to clamp and cut the cord. Obviously, this will be done with the mother with the cord intact. So the first clamp goes about 5 centimetres away from the umbilicus, about here. The second clamp can go a few centimetres away from the first clamp. Make sure both clamps are firmly shut. We then cut between the cord clamps like so, Just make sure that you're keeping out of the way of any of the baby's fingers or genitals. If the baby's well and you're able to maintain thermoregulation, you can ask one of the parents or family members if they would like to cut the cord.
So, if the baby does need immediate resuscitation, as you've just seen, in these cases you'll need to clamp and cut the cord sooner and move the baby to the resuscitation area. From there, you can start with stabilisation and any necessary interventions. It's a bit of a pivot from the delayed clamping approach, but the priority is always the baby's immediate needs. And sometimes things don't go according to plan. A snapped cord, for example. If this happens, you need to clamp the cord immediately. Then, watch the baby closely for any signs of hypovolemia like pale mucous membranes or respiratory issues. It's a rare occurrence, but knowing how to respond quickly can make all the difference. So, babies are born wet and they can become cold really easily, especially if they remain wet and exposed. We know outcomes are poorer and mortality is increased if babies get cold, so this is one of the most important steps for every birth. This flow diagram from RCUK summarises the steps involved with thermal care of the newborn, both term and preterm babies. Let's look at this in more detail.
So in this video, I'm going to talk through and demonstrate the key bits of thermoregulation. So at birth, in a term baby, it's very important to thoroughly dry the baby. Make sure the head is very dried. Then remove the wet towel and use dry towels to wrap the baby. As said before, in the first 60 seconds, this will all be done with the cord intact. Apply a hat to the baby. Make sure the baby is very well wrapped up. Thermoregulation for a baby is crucial at all times. This is because thermoregulation will ensure that the baby's lungs are more able to open and also that the baby doesn't get hypoglycemic, low blood sugar. We know that for every degree the baby is below 36.5, the mortality risk for the baby goes up by 28%. This is why thermoregulation is so important. You need to make sure that the environmental temperature is as warm as possible, both in the home or the environment that the baby's been born in, but also in the ambulance and on the way to hospital. It's important to monitor the baby's temperature using an axilla thermometer under the baby's arm, keeping the baby as wrapped up as possible. We want the temperature to be between 36.5 and 37.5. We need to monitor the temperature at birth, en route to hospital and on arrival to hospital as a minimum. We also want to make sure that there's no drafts, shut any windows, and everybody needs to be concentrating on keeping this baby as warm as possible. I'm now going to demonstrate thermoregulation for a preterm baby. Ideally, the baby should go in a plastic bag directly from birth, still wet. Get the plastic bag and make a hole in the other end for the baby's head. Gather up the plastic bag and put the baby in the plastic bag over its head like a poncho. Be gentle with a preterm baby's head so that we don't cause intraventricular hemorrhage. Once the baby is in the plastic bag, the baby must go on a heat source, which is your transwarmer mattress that has already been activated. Seal up the plastic bag so as to cause a greenhouse effect for the babies to get as warm as possible. Putting them in a bag also reduces insensible water loss from their respiratory system and also protects skin integrity. Once the baby's in the bag and on the transwarmer, wrap the baby in dry towels. You can then dab dry the baby's head and apply a hat to the baby's head. Be really careful to be very gentle. So which babies should go in a plastic bag? These are the babies that are born under 32 weeks gestation, or if you're not sure about the gestation, then if the baby is small enough to go in the bag, put the baby in a bag. If a baby is born unexpectedly small, for example following a twin pregnancy, then also put the baby in a plastic bag. Keep the baby wrapped up as much as possible If you do need to apply monitoring, such as the SATS monitor, unwrap them, apply the monitoring, the SATS monitor to the right hand, and then reseal as quick as possible. What you can do is leave the thermometer in the plastic bag, like so, seal it up, and then the button can be pressed whilst the baby is in the plastic bag. The transwarmer is stored in a box like this. It should be used at every birth. It's important to store the transwarmer in the box so that it doesn't activate itself during storage. When you know that you're going to have a baby, make sure you get the transwarmer available and ready. And the transwarmer, when it's out of the box, looks like this. So it has a liquid side and a material side. There's a coin that you need to locate. Click the coin and then the chemical will be released, which will make the transwarmer warm. You just need to squeeze it across the bag like so. The transwarmer works best when it's activated from room temperature. So if you are attending a birth, when the environmental temperature is low, then get the transwarmer out the box at the point that you know that you're going to need it, and put it into your coat, or make sure that somebody is getting the transwarmer up to room temperature. Once you've activated the transwarmer, squeeze the transwarmer like so, and then apply it to the baby like so. The baby should go on the material side of the transwarmer, and don't put any towels between the baby and the transwarmer. Monitor the temperature as discussed before in the axilla.
Your initial assessment of a newborn should be done as soon as possible because it will guide you towards any interventions that may be needed. This assessment involves just 4 components: colour, tone, breathing and heart rate. We don't need to worry about APGAR scores anymore. I find a mnemonic "can't take baby home" is useful to help me remember this.
So at birth you need to assess colour, tone, breathing and heart rate. An easy way to remember this is "can't take baby home." So during the first 60 seconds, you're drying thoroughly if it's a term baby, changing the wet towel and looking at the baby's colour, tone, breathing and heart rate. So for colour, we're looking for central perfusion. So we look at the mucous membranes, and what we don't want to see is central cyanosis. The hands and feet of the baby will be bluer, and that lasts for about 48 hours after birth. The baby will prioritise blood to its brain and its heart and away from the peripheries, so that's why we need to look centrally for good perfusion. In terms of tone, we want to see that the baby can flex all its limbs. If we see a floppy baby, then we would be concerned. In terms of breathing, we're looking at chest rise and adequate breathing. So a normal breathing rate for a baby is between 40 and 60 per minute. If we hear a baby making a noise with each breath, we call this grunting, and this would be a sign that the baby is probably too cold and needs respiratory support. The airway should be opened and the baby should be warmed up as much as possible. To assess the heart rate, use the stethoscope in the middle of the chest and listen for heart sounds. From a human factors point of view, what neonatal teams and midwifery teams in hospitals do is tap out the heart rate. Then everyone in the room knows what the heart rate is.
The next step after assessment is ensuring that the airway is open. This is the most common reason for a baby not to breathe by itself and is usually fixed by positioning the baby's head in a neutral position, with its face parallel to the surface that it's laying on. Floppy babies may need some chin support or a jaw thrust to help you open the airway, and sometimes a thin pad can be used under the shoulders to help maintain the neutral position, but it's important not to overextend the head, as this can also lead to airway obstruction. The next step for a newborn that is not breathing is to provide inflation breaths. These replace the amniotic fluid that's in the lungs with air, and it starts a chain of events which helps the baby transition to life outside the womb. Now usually amniotic fluid is squeezed out of the lungs as the baby passes through the birth canal, but sometimes we do need to do a little more by delivering these inflation breaths. Let's have a closer look at this and airway management in the next slides.
So once you've identified that the baby needs resuscitation and you've clamped and cut the cord, the baby should be brought over to your pre-prepared resuscitation area. The first step is to get the baby's head into a neutral position. So this is where the face of the baby is parallel to the floor. Once you've got the baby into a neutral position and you've assessed that the baby needs resuscitation, then the next step is to provide inflation breaths. The purpose of inflation breaths is to replace the lung fluid that will be in the baby's lungs at the point of birth with air. So we need to inflate those lungs for the first time, because when the baby's in utero, they're not using their lungs. So we need to replace the lung fluid by doing 5 long, slow inflation breaths. For the mask size, we size it by doing a line, roll, check. The mask needs to cover the mouth and the nose of the baby. So for this baby, which is a term baby, this is the correct size mask because it covers the nose and the mouth. We then, off of the baby, apply the mask to the bag valve mask. You can check that the blow-off valve is working by occluding the hole in the middle of the mask. We then need to have the baby's head into the neutral position, align, roll, check, and then it's the 3 P's. So position, that's covering the nose and the mouth, and then pressure, you're applying pressure in a downward motion to the floor, and pull, the jaw gets pulled up into the mask. You're now ready to deliver your 5 inflation breaths. 1, 1, 1. 2, 2, 2. 3, 3, 3. 4, 4, 4. 5, 5, 5. Whilst you're doing the inflation breaths, it's really important to observe for chest rise. You may not see chest rise on the first view, but you should see chest rise by the 5th one. That will tell you that the lungs are now inflated. You now need to assess the baby again. This is breathing and heart rate. Is the baby spontaneously adequately breathing? And what is the heart rate? So assess the baby's heart rate. You can tap out the heart rate so that everyone in the room knows what the heart rate is. In this situation, if you haven't seen chest rise or an increase in heart rate, then you need to repeat the inflation breaths. So what you can do is try and reposition the baby. Make sure the baby's head is off of the transformer, which will give you a nice neutral position. Or you can use an advanced airway, which will be demonstrated shortly. Once you've made an adjustment to the airway, repeat your 5 inflation breaths. Do the align, roll, check, position, pressure, pull, and deliver the 5 inflation breaths. Another option is a 2-person technique, and we're now going to demonstrate that. Put your palms on the forehead of the baby to stabilize the baby's head. Put your thumbs on the baby's cheekbones, and then with your other fingers, find the angle of the jaw. Lift the baby's jaw upwards directly towards the ceiling. Your assistant then needs to do the align, roll, check with the bag valve mask. As they do so, remove your thumbs and apply them to the top of the mask, as close to the stem as possible. They're now going to deliver the 5 inflation breaths. 1, 1, 1, 2, 2, 2, 3, 3, 4, 4, 5, 5. The 2-person technique should be prioritized as soon as possible when attending to a preterm baby. This is because the evidence shows that this is the most successful way of getting lung inflation. If you've not seen chest rise or an increase in heart rate when you've done your inflation breaths, another option is to put in an eye gel. This could also be prioritised if you were attending alone. An eye gel should always be put in with a Miller laryngoscope. The laryngoscope is a left-handed instrument. You hold it in your left hand, you point it towards the legs, and you need to protect the top lip. So it's all the L's. Protect the top lip and sweep the tongue over so that you can visualise the airway. You need to maintain a neutral position. You're only using the laryngoscope as a tongue depressor. Do not use the laryngoscope in the same way that you would in an adult. If you visualise anything in the airway, such as meconium or vernix or a blood clot, you can suction under direct vision exactly what you see. Do not go too deep with the suction because this can cause a vagal response. Once you've made sure that the airway is clear, the eye gel, which should be prepared with some lube beforehand, or you can use the saliva in the baby's mouth, should be applied like so. Once you feel resistance, remove the laryngoscope gently. Once the eye gel is in place, maintain the head in a stable position and apply the bag valve mask. Remember to push downwards rather than lift the eye gel up out of the baby's mouth. You can now repeat your 5 inflation breaths. 1, 1, 1, 2, 2, 2, 3, 3, 3, 4, 4, 4, 5, 5, 5. You're observing for chest rise. You will then assess breathing, whether it's spontaneous, adequate breathing, and also your heart rate.
So as we've said, the aim of inflation breaths is to open the alveoli and move fluid out of them and into the pulmonary circulation. You should always start on air to reduce the risk of over-oxygenation, which can include problems such as blindness. Give 5 inflation breaths, sustaining the inflation pressure for 2 to 3 seconds each time. Be careful when squeezing the bag, aiming for consistent but not forceful delivery with enough pressure to see the chest rise gently. Moving on, the next step for a newborn that is not breathing is ventilation breaths. These are to support breathing and are more like what we're used to delivering during resuscitation. In newborns, the rate is 30 a minute with reassessment after 15 breaths, which is 30 seconds.
Once you've done your inflation breaths successfully, we reassess the heart rate and breathing. Could you assess the heart rate for me, please? And the baby's not breathing. So we now need to give ventilation breaths. Whatever airway you've used to successfully get inflation breaths, you should continue with that airway, whether that be a 2-person technique, an eye gel, or if you've got a successful neutral position. So we've just had our successful inflation breaths. We've assessed that the heart rate is low and the baby's not breathing. So we're now going to deliver ventilation breaths. These are 1 second on and 1 second off. You're breathing for the baby. You do 15 over 30 seconds before reassessing. You should monitor for chest rise throughout the time that you're giving ventilation breaths. 14, 15. We would now reassess.
And while you're providing interventions, don't forget to reassess colour, tone, breathing and heart rate every 30 seconds. Okay, chest compressions. Now this is the scary bit, but remember that only a tiny proportion of newborns need this intervention. If heart sounds are absent or the rate is below 60 beats per minute after the first 30 seconds of adequate ventilation breaths, then chest compressions should be started. The ratio is 3 compressions to 1 ventilation breath, which reflects the importance of ventilation in newborns. So if you do find yourself delivering chest compressions, then keep going if the heart rate is below 60 a minute, even if the baby starts to breathe on their own. Oxygen should always be started if chest compressions are being given, and you'll want to be thinking of how you are going to get the baby to a hospital with maternity unit and neonatal support for advanced interventions if they're needed.
14, 15. Okay, we're now going to reassess. Okay, so we have been seeing chest rise with our ventilation breaths, but the heart rate is below 60, so we now need to start chest compressions. So if you could do the encircling technique. So Lorna is pressing a third of the depth of the chest. She's found the nipple line with her thumbs. She's encircling the baby, trying to keep the baby as warm as possible whilst doing this. I'm going to give 1 breath, and then she's going to give 3 chest compressions. We're compressing a third of the depth of the chest and allowing for good recoil in between. We're going to do this for 15 cycles before reassessing. At this point, you may want to secure an airway if you haven't done already by using an eye gel, like is demonstrated here. You also need to add oxygen at this point. And if you have enough resources, add a saturations probe. You also need to start making plans for extrication and getting to hospital, because once we get to chest compressions, this baby is likely to need advanced neonatal support. We've now done 15 cycles, so we're going to reassess the heart rate and breathing. If the heart rate remains slow, we're going to continue with a ratio of 3 to 1, as was demonstrated. If the heart rate was now fast, we would go back to ventilation breaths if the baby wasn't spontaneously adequately breathing. In a preterm baby, you might want to use 1 finger, just ensuring that you're still compressing a third of the depth of the chest. If you were on your own and you needed to start chest compressions, then you would secure an airway, as has been demonstrated. Have the bag valve mask resting on your forearm and use the 2-finger technique to compress the chest. Try to ensure you're still compressing a third of the depth of the chest.
Remember to keep giving chest compressions until the heart rate is above 60 a minute, and support ventilation if the respiratory rate is below 40 a minute. And while you're providing interventions, don't forget to reassess colour, tone, breathing and heart rate every 30 seconds.
So what happens next? Even if the baby has fully recovered after you've provided support, whether it was just inflation breaths or full resuscitation, they need to go to hospital because they're at risk of deterioration without further help. You should liaise with local hospitals so you're met by an appropriate team when you get there and you know which part of the hospital to meet them at. This will usually be the emergency department, but some hospitals may have different protocols. And make the transfer easier for yourself and maintain the effectiveness of any interventions you're providing while on the way. If you're providing respiratory support, for example, an eye gel may be a good idea for transfer, even if you're achieving good ventilations with just a mask.
All babies will need the first 4 steps. Some will need help with opening their airway, and some of those will need inflation breaths to aerate the lungs. A few babies will need help with their breathing from delivery of ventilation breaths, and very few, like 3 in 1,000, will need chest compressions. But most of these will respond really well when they're provided with good ventilation breaths too. So let's put all this together and see how it works in a term baby.
Hello.
Hello.
The ambulance service here.
Hello.
Oh, you've had your baby. Congratulations.
Thank you.
I'm Shabella, and this is Matt.
I'm Lorna. She doesn't seem quite right.
An area for the baby. Okay, let's just try the baby off. Okay. So we might need to give your baby a little bit of help to get going, okay?
Okay.
We've called for backup as well. Brilliant.
Okay.
Awesome. Yeah, so we just need to give her a bit of a kick start. If you just hold on to her there, I'm just going to change this one. If you can activate the transformer as well, please. Thank you. All right, let's just put a hat on. I'm just going to see whether this will help her.
So she's
And
not
then-
crying, is she?
Yeah, let me just put a clock here. Resuscitation.
She come out about a couple of minutes ago.
Okay, so we're just going to properly stimulate her. Okay, I need to just take her over to this area to give her a little bit of help. Okay,
Okay.
and one of my colleagues is going to be here soon just to take care of you. Okay, so we're just going to put and the clamp on. How many weeks pregnant were you?
I'm due tomorrow,
Okay,
so yeah.
and how many minutes has the baby been born?
Oh, only about 2 before you come. They
Okay,
literally just
okay,
come
fine.
out.
Can I just take her over here?
Yeah.
Okay, and one of my colleagues will be there shortly. Okay. Hi there. Yes, please. Yeah, thank you. Okay. That there. Just have a proper assessment. I saw over by Mum that she was centrally cyanosed and and very floppy.
Yeah.
And not breathing, so that's why I just brought her here. I've got to just turn the transformer over for me. Let's just have a proper assessment. Okay, so neutral position. Okay, I'm going to do some inflation breaths. If you can do the heart rate assessment for me. Lovely. Okay. So 1, 1, 1, 2, 2, 2, 3, 3, 3, 4, 4, 4, 5, 5, 5. So there was good chest rise. Heart rate's still very low. Okay. All right, baby's not breathing. So let's just do ventilation breaths. You just look at the clock for me.
Absolutely. Yeah. There's a clock up there, yeah.
And
30 seconds.
13, 14, 15. Let's just reassess. I can see the baby's not breathing.
Yeah.
So just reassess the heart rate for me.
Still slow.
Very slow. Okay, we need to start chest compression.
Yep.
Guys, just to let you know, we're just going on to chest compressions over here.
Ready?
So what I'm going to do is just upgrade this
Yeah.
to Nigel very quickly. So thanks for getting all this ready.
You're welcome.
Alright, if you can just be ready for that. Yeah, there's actually some meconium here, so I'll just get that out. We were seeing good chest rise, but so just completely clear, obviously. Yeah, thank you. You can just add some oxygen.
Yeah.
Alright, thank you. Okay. So if you can start chest compressions.
1, 2, 3.
If one of you's
Two.
free to come
Yeah.
put a SATS probe
1,
on,
2,
that'd be
3.
brilliant. Thank you.
1, 2, 3.
Is Mum doing okay?
Yeah, Mum's doing okay. Bob's all
You
normal.
need to get to the right side. Ask me to move.
Yeah, is it okay?
7, 8, 9, 10, 11, 12, 13, 14, 15. Reassess? Yeah. Okay, still slow.
Yeah.
We just continue chest compressions. Yeah, we'll see what these sets are. Thank you. When you've done that, if you didn't mind just popping a thermometer around.
Okay.
Thank you.
Okay, so that's frozen now.
10, 11, 12, 13, 14, 15. Just reassess.
Yeah.
Brilliant. Okay, so we'll just do some ventilation breaths because this baby's not breathing.
Do you want me to prepare for extrication?
Yes, please, yeah. And if you can crank the heating on the ambulance.
Yes, certainly. I'm going to do that.
Lovely. Do you mind, there's a thermometer, if you can just pop that on, that'd be great. Thank you. Could you just have a look into that? Sorry, I know I'm asking you a lot of do a lot of things at the same time. It's just up for the reassessment now. Brilliant. Okay, so still just continue with that. Thank you.
Okay, so I've got the flap splint for the extrication.
Lovely. Okay.
So when you happen to lift her up slightly once we've got that temperature.
Yeah. We'll just check that the guys with mum are happy for us to go first.
Yeah, are you happy?
Yeah,
that's good. Yeah.
We're just getting the transporting results for mum coming.
Yeah. Thank you.
We just reassess when somebody can grab a stethoscope.
Okay, thank you.
So if you and perhaps something to lift, then I'll fly them lift. Yeah. Very happy. Let me know when you're ready. Come on.
Yeah, ready.
Yeah.
1, 2, 3, lift. Lovely. If you can give me the stethoscope, then we can just listen between.
Okay.
Just to check we're on the right. Thank you. Yeah. Right, lovely. Heart rate's good.
That's in, yeah. Instant secure. Right, yeah.
You happy with mum over there? Yeah.
That's good. Sorry. Okay, just keep transporting.
Is there any partner that wants to come with us?
We've got the number for our husband.
Does it work? Lovely, okay, so they'll meet us at the hospital. We're going to take your baby, they're in good terms, okay?
Is she breathing?
Not herself, we're breathing for her, but her heart rate's good at the moment, okay? So we just need to take her to get a bit more support.
Okay.
You guys just let me know when you're ready.
We're about there, I think, yeah.
Okay. Shall we? I'll just have one little listen again. Yeah, it's lovely. Okay, ready?
Check that, I'll take
We can actually remove the oxygen now because I can see that the sats are 95%.
Great.
Yeah.
Should we take one side each of this room?
Yeah.
So they'll just do
Okay.
Yeah.
1, 2, 3, go.
In preterm babies we use exactly the same approach with a little modification like not drying a baby and putting it in a plastic bag to help with thermal care. Sometimes we may not know the gestation of the baby, so remember, if it looks like the baby will fit in a bag, put it in a bag. Let's see how all this goes together.
Have you had any problems in your pregnancy?
No.
Okay, just keep the baby nice and warm. And if the baby hasn't perked up, I'm just gonna have a listen. Okay. Okay, it's quite slow. So what I'm gonna need to do is just clamp and cut the cord and take the baby over there. Well, me and my colleague are just gonna support the baby. Okay. Essentially, we just need to see what the baby needs from us, okay? And then we'll explain everything. Okay. Some more of our colleagues are coming to help you, okay? If you feel unwell at any time, if you can just shout out to us, okay? We're not far away.
Please look after her.
Yeah, we will. We'll take very good care of her. Just take all of this. All right.
Hi guys, it's
Hi there. Yes, please. Yeah. We've got a preterm baby needing resuscitation.
My name's Lorna.
So, lovely. Could you put a sat probe up there for me, please? It's actually a bit wet, that towel. So.
It's probably only about
The
5
neutral
minutes.
position. We just move her slightly off the.
No,
Lovely. Brilliant.
That's dry.
Thank you.
Okay.
Okay.
I'm not worried about her.
It looks like she's an inflation breast. So, let's see. Can you have a listen to the heart rate as well with me? Oh, lovely. Okay. Oh, that's better than it was. Okay, lovely. So, just note the time for me as well. 1, 1, 1, 2, 2, 2, 3, 3, 4, 4, 4, 5, 5, 5. Oh, brilliant. Okay, but not breathing. We did see good chest rise, didn't we, there? Yeah. Lovely. 4, 5, 8,
My
9.
husband's at work. The number's on the fridge.
Okay, do you want to reassess? Oh, it's actually dropped. Guys, does anyone able to just come and help us, please?
Yeah.
Okay, let's start chest compressions. If you could just add the oxygen.
Yes, absolutely.
Yeah. Yeah. Okay. Thank you. Is Mum doing okay? 8, 9, 10, 11.
Yeah, I just feel tired.
14.
I'm okay, I'm just worried about her.
14, 15. Let's reassess now. Very slow. Okay, can we do a two-person technique, please? Okay. Do you mind doing the chest compressions for us? Thank you.
Yeah, it's just 8 months and like 2 or 3 days.
Okay. Yep. 2, 3, 4, 5, 6, 7, 8, 9, 10.
No, everything's
11.
been fine. I've not had any problems
12.
at all. I had a check up yesterday as
13.
well.
14, 15. Okay, let's just reassess.
Yeah, I want to see what they're doing.
Okay, still need to do chest compressions. Okay. We're seeing good chest rise though, aren't we? Yeah. Okay. So the airway's good. Yeah. Let's go for it. 3 to 1. And then we can see if a colleague is able to help prepare for extrication.
Stuart, have you got that back?
Yes, I'll try.
You'll be able to help us out with here.
I'm just going to go and hop back in there, okay?
Okay, thank you.
14, 15. Okay, let's reassess. Okay, so we need to extricate whilst we're doing chest compressions with a two-person technique, ideally. So if you could just crank the ambulance heating, prepare the pathway and the vac splint. Okay, let's continue as we're doing. So getting good chest rise. Yeah. Okay, we've got oxygen attached. Yeah, brilliant. Okay, so stats are reading 90%. So that's good. We're at how many minutes? Oh, 4 minutes. Okay, so that's pretty good actually. Okay, so what we're doing is working, but we just need to get this baby to definitive care really now. Awesome. Okay, so just to recap, we've got a baby at about 28 weeks, looks like. Sats are 90%, receiving CPR. Have a listen to the heart rate, and we need to go to the nearest ED, put in a pre-alert. Just make sure in the pre-alert that it's really clear that it's a preterm baby at 27 weeks.
Okay.
One at 27
Heart rate's increasing.
Brilliant. Okay. Yeah. Okay. Awesome. So
Yeah.
let's get that.
Yeah.
I'm going to keep hold of the airway, okay? Ready? 1, 2, 3. Lovely. And the SATS monitor still on, isn't it? Yep. And if one of you could just reassess once you get a second. Get a good chest rise. Yep. Lovely.
Yeah.
Very good. Okay. Lovely. So the plan is we're going to do one more reassessment before we move. You feeling okay, Mum?
Yeah.
Brilliant. Okay. Brilliant. Okay. Yeah, the stats are still 90, so I think we're nearly 10 minutes, aren't we? So we'll carry on with the oxygen. Yeah, we're not over oxygenating. So okay. Yeah, ready, guys?
Yeah.
Let's go. Ready, steady, go.
We hope you found this useful so far, and remember, most babies handle the transition to life outside the womb like absolute pros. 85% of them breathe spontaneously without any help, and for the rest it's just another 10% who need some drying and a bit of stimulation or airway opening manoeuvres, and they're off to a good start. About 5% will require positive pressure ventilation, but advanced airway interventions are only required in less than 2% of cases. Needing to provide chest compressions is really rare, but we must be prepared for anything. Let's go over the key points before looking at packaging, transport and monitoring. So, keep the environment as warm as possible and prepare an area in case any interventions are required. Ensure optimal cord clamping unless immediate resuscitation is needed, and assess colour, tone, breathing and heart rate, remembering to repeat this every 30 seconds while interventions are being provided. Babies become cold really easily, so if they're term, dry them and remove any wet towels, wrap them with dry ones. If they're preterm, then don't dry them but put them in a bag. Use a hat and other measures such as thermal mattresses if required. Skin to skin is a safe and effective way of keeping babies warm if they're well. If interventions are required, then ensure the airway is open by placing the baby on their back with the head in the neutral position. If the baby is still not breathing adequately, then give 5 inflation breaths lasting 2 to 3 seconds each, and then check heart rate and chest movement every 30 seconds. If the chest isn't moving or the heart rate is slow, then check your airway manoeuvres are effective and repeat the inflation breaths. If the lungs are aerated but the baby is still not breathing by itself, then deliver 30 seconds of ventilation breaths at a rate of approximately 30 breaths a minute, confirming the chest movement as you do this. If the chest is moving with ventilation breaths but the baby is not breathing by itself, then continue to support it with ventilation breaths. If the heart rate is absent or below 60 beats per minute, then chest compressions are needed and 100% oxygen should be started. Before you transfer the baby, make sure the ambulance is toasty warm and pre-alert the receiving hospital to inform them of the situation and confirm where to meet the receiving team. Requesting additional resources for safe transportation of both mother and baby may be necessary depending on your local protocols. Securing the baby safely for transport is really important, and your local guidelines should be followed as the devices you have to achieve this will vary between services. And it seems obvious, but good communication and ensuring that both mother and baby go to the same hospital are vital. Remember, you should never put a newborn requiring additional support or monitoring in a car seat for transport. This increases the risk of airway obstruction during transfer, And while skin to skin is great for thermal care, it may also increase the risk of unrecognised airway obstruction. So remember to keep the ambulance warm and use thermal mattresses and blizzard blankets if available. Now, newborn babies all look the same to me, so it's really important to apply ID bands with the mother's name and postcode written on them. This just avoids any awkward situations in the hospital, especially if mother and baby are transported separately. It's also important to make sure that maternity staff know where everyone is so that they can be reunited as soon as possible. After every birth, the mother and the baby or babies require at least 2 sets of observations from either the ambulance service or the midwives if they're around. Document the observations on individual patient records and obviously act on any abnormalities using the parameters on the maternity decision tool for ongoing assessment of the mum and those on the page per age and care of the newborn guidelines for ongoing assessment of the baby. We've said how important thermal care is, and temperature recordings should be taken with an appropriate thermometer as soon as practical after birth, at least once during transport and then again when arriving at the destination. Oxygen sats should also be monitored during transport of preterm babies or any baby that has undergone any form of intervention or support. Babies with abnormal findings on assessment or babies that are requiring ongoing airway support also need continuous oxygen sats monitoring.